Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 277 of our pharmacotherapy series, which majors in essential hypertension. The first question reads, BCA is a 58-year-old woman who is postmenopausal, does not smoke, and never drinks alcohol. Since being diagnosed with hypertension, she has modified her diet, begun routine aerobic exercise, and has lost 10 kilograms in the past 18 months. She now weighs 72 kilograms and is 165 centimeters tall. Her BP is now 150 systolic 94 diastolic. It was 150 systolic 92 diastolic when repeated, and has consistently remained near this value for the past year. Her BP when first diagnosed was 156 systolic 96 diastolic. Physical examination shows no left ventricular hypertrophy and no retinopathy. Urinalysis is negative for protein. Other laboratory tests are normal, except for dyslipidemia. BCA has no health insurance and is concerned about the cost of therapy. She takes over-the-counter calcium with vitamin D, and her provider wants to start hydrochlorothiazide 25 mg per day. Is hydrochlorothiazide an appropriate agent for BCA? BCA is a primary prevention patient with uncontrolled hypertension. According to the JNC8, her BP goal is less than 140 systolic 90 diastolic. Initial monotherapy is reasonable. Appropriate first-line treatment options include an ACE inhibitor, angiotensin II receptor blocker, calcium channel blocker, or thiazide diuretic. All of these drug classes have generic options and should be easily affordable for BCA. A thiazide diuretic may also benefit her osteoporosis and is an appropriate choice. Several types of diuretics are used to manage hypertension. All lower BP, with differences being duration of action, potency of diuresis, and electrolyte abnormalities. We will now briefly consider thiazides. Thiazides are diuretics of choice for most patients with hypertension. Similar to loop diuretics, an initial diuresis is experienced. After approximately 4 to 6 weeks of thiazide diuretic therapy, diuresis dissipates, however, and is supplanted by a decrease in pulmonary vascular resistance, which is responsible for sustaining antihypertensive effects. The next question reads, how should a thiazide diuretic be started in BCA? Hydrochlorothiazide versus chlorthalidone. Hydrochlorothiazide and chlorthalidone have been used in several major outcome trials, although only chlorthalidone-based regimens have proven to be of benefit in the low doses commonly used in practice today. Both agents are inexpensive and dosed once daily, but hydrochlorothiazide is most frequently used in the United States and is more widely available in fixed-dose combination products. The usual starting dose of hydrochlorothiazide or chlorthalidone is 12.5 mg once daily. A maintenance dose of 25 mg once daily can effectively lower BP and has a low incidence of side effects, e.g., hyperkalemia and hyperuricemia, that can be managed with routine monitoring. Significant controversy surrounds the comparative efficacy of hydrochlorothiazide and chlorthalidone. Most clinicians, including the AHA, assume a class effect for these two drugs. However, class effects can be legitimized only after assurance of equipotent dosing. For antihypertensives, when they are not directly compared in a cardiovascular event trial, it assumes that if two agents achieve similar BP lowering, then both achieve similar reduction in cardiovascular events. With regard to hydrochlorothiazide and chlorthalidone, this assumption is unproven. Chlorthalidone is more potent on a milligram-per-milligram basis and has a longer half-life than hydrochlorothiazide, 50 to 60 hours versus 9 to 10 hours. Based on a comparative study using 24-hour ambulatory blood pressure monitoring, it appears that the equipotent dose of chlorthalidone 25 mg daily is hydrochlorothiazide 50 mg daily, but this dose of hydrochlorothiazide is unpopular because of increased side effects. Consequently, it is believed by some that the antihypertensive efficacy of chlorthalidone is greater than hydrochlorothiazide when contemporary doses are used. The 12.5 to 25 mg doses of chlorthalidone do not appear to significantly increase the risk of hyperkalemia more so than hydrochlorothiazide. Complicating this issue is evidence demonstrating that office BP tends to overestimate the response to hydrochlorothiazide, and the 24-hour BP lowering with hydrochlorothiazide is only comparable to other common agents: ACE inhibitor, angiotensin II receptor blockers, calcium channel blocker, and even beta blocker, when 50 mg daily is used. Recently, data from the multiple risk factor intervention trial indicate that chlorthalidone reduces cardiovascular events more than hydrochlorothiazide. Although chlorthalidone is the most optimal and evidence-based thiazide diuretic for BCA, hydrochlorothiazide remains currently accepted in the clinical environment as a reasonable thiazide diuretic for hypertension, assuming her BP goal can be readily achieved with its use. Next we will look at loop diuretics. Loop diuretics produce a more potent diuresis, but a smaller decrease in pulmonary vascular resistance, and less vasodilation than thiazide diuretics. They are subject to a significant post-dose antinatriuretic period, which offsets their antihypertensive effect. Therefore, a thiazide is more effective at lowering BP than loop diuretics in most patients. Loop diuretics are usually considered only for patients with severe chronic kidney disease, estimated GFR less than 30 ml per minute per 1.73 meters squared, left ventricular dysfunction, or severe edema. In these patients, potent diuresis is often needed. Furosemide has a short duration of effect and should be given twice daily when used in hypertension, whereas torsemide has a longer duration of action and can be given once daily. Next we will discuss potassium-sparing diuretics. Potassium-sparing diuretics, such as triamterene and amiloride, should be reserved for patients who experience hyperkalemia while on a thiazide diuretic. With low-dose thiazide diuretics, less than 25% of patients develop hyperkalemia, and most cases are not severe. Triamterene and amiloride usually do not provide significant additional BP lowering when added to a thiazide diuretic. Several fixed-dose products are available that include hydrochlorothiazide with triamterene or amiloride. Empirically, starting all patients with hypertension treated with a thiazide diuretic on triamterene or amiloride to avoid hyperkalemia is not rational or necessary unless baseline serum potassium is in the low normal range. A thiazide diuretic is an optimal first-line option in primary prevention in patients like BCA, and she has no contraindications. Although BCA has dyslipidemia, thiazide diuretics are unlikely to have a clinically significant effect on cholesterol when used in low doses. An appropriate starting dose of hydrochlorothiazide is 12.5 or 25 mg daily. BCA has no additional risks for orthostatic hypotension, so starting at the higher 25 mg daily dose is safe and will have a better chance of lowering her BP to goal than the lower 12.5 mg dose, because most antihypertensive agents provide a 10 mm of mercury reduction in SBP and 5 mm of mercury reduction in DBP with a standard starting dose. The next question reads, BCA is prescribed hydrochlorothiazide 25 mg daily. How should she be counseled regarding this therapy? Some patients disregard lifestyle modifications when they start antihypertensive therapy, so BCA must be encouraged to continue lifestyle modification to maximize her response to drug therapy. BCA should be informed that diuretics lower both BP and risk of cardiovascular events, and that taking her dose at about the same time each morning to minimize nocturia and provide consistent effects is recommended. BCA should expect to experience increased urination when starting hydrochlorothiazide, but should be informed that this diminishes with time. Inform BCA that missed doses should be taken as soon as possible within the same day, but doubling doses the next day is not recommended. The potential for hyperkalemia, which is easily identified and managed, and the need for routine monitoring of serum potassium should be reviewed. She should be counseled on the signs and symptoms of electrolyte abnormalities, e.g., leg cramps and muscle weakness, and encouraged to report these to her healthcare provider if they occur. Increasing dietary intake of potassium-rich foods to minimize electrolyte depletion is an option to minimize potassium loss. This should be encouraged only with thiazide and loop diuretics, but not with potassium-sparing agents. Despite improvements with lifestyle modifications and reported adherence with hydrochlorothiazide, BCA's goal BP of less than 140 systolic 90 diastolic has not been met. Her BP average is 141 systolic 83 diastolic. No new signs of hypertension-associated complications are seen. She should be encouraged to continue with her current efforts, but other interventions are warranted. The next question reads, after 4 weeks of hydrochlorothiazide 25 mg daily, BCA has no complaints and has not missed a dose. She is exercising and is following the DASH diet. Her BP values are 142 systolic 86 diastolic. It is 140 systolic 84 diastolic when repeated. Her fasting laboratory values are as follows. Serum potassium is 3.8 milliequivalents per liter. Uric acid is 7.3 mg per deciliter. Glucose is 99 mg per deciliter. All other values are unchanged. Last month, potassium was 4.0 milliequivalents per liter. Uric acid was 6.8 mg per deciliter, and fasting glucose was 95 mg per deciliter. What is your assessment regarding the efficacy and toxicity of BCA's antihypertensive therapy? Let's first look at potassium loss. Adverse reactions with low-dose thiazide diuretics, e.g., hydrochlorothiazide 12.5 to 25 mg daily, are minimal compared with higher-dose therapy, hydrochlorothiazide dosed above 25 mg daily. Moreover, side effects and tolerability with low-dose thiazide diuretic therapy are similar to other first-line drug therapy options and not much higher than what is seen with placebo. Regardless, signs and symptoms of electrolyte and metabolic changes, such as hyperkalemia, hyponatremia, hyperglycemia, or hyperuricemia, should be evaluated in all patients treated with thiazide diuretics. BCA has experienced small changes in serum potassium and uric acid, which are typical thiazide-induced abnormalities. BCA should be questioned about muscle cramps or weakness, which can be caused by decreased potassium. The next question reads, is BCA's potassium decrease concerning? If so, how should this be managed? Most total body potassium is intracellular, that is approximately 98%. Thiazide diuretics can cause potassium loss and can result in potassium serum concentrations in the low end of the normal range. However, with low-dose therapy, overt hyperkalemia is not common. Hydrochlorothiazide in doses of 12.5, 25, and 50 mg daily can decrease serum potassium by an average of 0.21, 0.34, and 0.5 milliequivalents per liter, respectively. This is usually considered mild, with serum potassium concentrations reaching a nadir within the first month of therapy and remaining stable thereafter. Restriction of dietary sodium in patients receiving diuretic therapy has been shown to reduce the loss of potassium and should be encouraged in BCA. The next question reads, when is potassium correction needed to manage diuretic-induced hyperkalemia? BCA's potassium is within the normal range. Potassium replacement is not indicated. Diuretic-associated hyperkalemia should be treated when serum concentrations are below normal regardless of whether symptoms, e.g., muscle cramps, are present. Serum potassium should be measured at baseline and 2 to 4 weeks after initiating therapy or increasing the diuretic dose. Potassium-rich foods, e.g., dried fruit, bananas, potatoes, and avocados may help prevent small decreases in potassium, but they cannot be used as sole therapy to correct hyperkalemia. For instance, one medium-sized banana has only 11.5 milliequivalents of potassium. The usual replacement dose of prescribed potassium chloride is 20 to 40 milliequivalents per day but can range from 10 to more than 100 milliequivalents per day. Potassium chloride, bicarbonate, gluconate, acetate, and citrate salts are available for potassium replacement therapy. Rather than supplement potassium, which does not effectively correct the underlying mechanisms responsible for hyperkalemia, a more appropriate and effective strategy to manage diuretic-induced hyperkalemia is to add a potassium-sparing diuretic. Hypomagnesemia often accompanies diuretic-induced hyperkalemia and must be normalized before hyperkalemia can be effectively reversed. The next question reads, how should the increase in BCA's uric acid be managed? Thiazide diuretics can increase serum uric acid concentrations in a dose-dependent fashion. Uric acid increases also occur with loop diuretics, but to a lesser extent. Increased proximal tubular renal reabsorption, decreased tubular secretion, or increased postsecretory reabsorption of uric acid contributes to diuretic-induced hyperuricemia. Thiazide-induced hyperuricemia is usually small, that is equal to or less than 0.5 mg per deciliter, and is not clinically significant in patients without a history of gout. For patients with a history of gout, diuretics are not contraindicated, but an increase in serum uric acid may require a decrease in dose or possibly discontinuation of the diuretic, especially for those not on preventive antihyperuricemic therapy, e.g., allopurinol and febuxostat. Acute gouty arthritis precipitated by diuretic therapy should be treated, and the diuretic should be discontinued, at least temporarily. Future use of the diuretic will depend on whether long-term antihyperuricemic therapy is to be added and the risk versus benefit for continuing the diuretic. BCA's serum uric acid concentration is elevated, but switching to a different agent or lowering the dose of hydrochlorothiazide is unnecessary because she is not symptomatic of gout. It should be noted that changes in parameters such as uric acid can be informative regarding dosing. When a given dose of a diuretic fails to lower BP, it is often unclear as to whether the failure is a result of mechanisms other than volume driving the hypertension or a result of the diuretic dose being insufficient to achieve the desired physiologic effect. For example, the absence of an increase in uric acid suggests that the administered dose was insufficient, and that a higher dose merits consideration. In BCA's case, the increase in uric acid confirms that the given dose was sufficient to have had a physiologic effect, so adding an antihypertensive agent from a different drug class would be preferable to increasing the diuretic dose if further BP lowering is necessary. The next question reads, how much will hydrochlorothiazide alter BCA's cholesterol values? Small increases in LDL cholesterol and triglycerides are potential side effects of diuretic therapy. Dietary fat restrictions help minimize, but do not necessarily prevent, these effects. Contrary to other biochemical disturbances, diuretic-induced changes in the lipid profile are not dose-related, and overall changes are small. Many clinical trials lasting more than 1 year have shown that these alterations with diuretic therapy are not sustained with prolonged use. Even if these changes are persistent, they are very small and are not clinically significant. The presence of dyslipidemia should never be a reason to avoid diuretic therapy. The next question reads, what other potential electrolyte abnormalities should be evaluated in BCA because of her thiazide diuretic therapy? Hyponatremia is a serious, yet infrequent, adverse effect of diuretics. Changes in sodium concentrations are usually small, and the majority of patients are usually asymptomatic. Frail, elderly women appear more susceptible to experiencing severe hyponatremia, that is below 120 milliequivalents per liter from diuretics, which rarely occurs, but definitely requires discontinuation of therapy. Attention should be paid to the presence of other medications that can contribute to hyponatremia, e.g., selective serotonin reuptake inhibitors and psychotropic drugs, and patients should be counseled to avoid excessive free water intake. Hypomagnesemia is an often overlooked metabolic complication of diuretic therapy. Both thiazide and loop diuretics increase urinary excretion of magnesium in a dose-dependent manner. Symptoms of significant hypomagnesemia include muscle weakness, muscle tremor or twitching, mental status changes, and cardiac arrhythmias. Presence of these symptoms would necessitate magnesium supplementation or use of a potassium-sparing agent as noted above if hyperkalemia is also present. Thiazide diuretics decrease urinary calcium excretion and can be used to prevent calcium-related kidney stones. The retention of calcium does not significantly increase serum calcium concentrations and does not place patients at risk for hypercalcemia. This effect, however, may be beneficial in women at risk for osteoporosis, e.g., postmenopausal, such as BCA, or in patients with osteoporosis. Conversely, loop diuretics increase renal clearance of calcium. The next question reads, what are common reasons for inadequate patient response to antihypertensive pharmacotherapy? BCA has been on her current dose of hydrochlorothiazide for 4 weeks. The full antihypertensive effect of hydrochlorothiazide has been achieved, but she still has uncontrolled hypertension. She has had a response, but it remains inadequate. Potential reasons for an inadequate response, or lack of attaining BP goal values with an antihypertensive should be considered before modifying her drug therapy regimen. A comprehensive medication history and medical evaluation is needed to rule out identifiable causes, in particular non-adherence to the prescribed regimen. Her BP reduction with hydrochlorothiazide is typical. Her kidney function is good, and no evidence exists of edema, so volume overload is unlikely. There are no apparent secondary causes of elevated BP. It is reasonable to conclude that BCA needs additional therapy to achieve her goal BP. It is very common that most patients require 2 or more agents to attain BP goal values. Let's now briefly discuss modifying therapy. When patient cannot achieve optimal BP control with initial antihypertensive, JNC8 recommends that the dose of the first drug may be increased, if patient has not yet achieved maximum dose of the agent, or low dose of a second agent may be added. Second agents of choice would be ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, or thiazide diuretics, whichever one the patient is not already taking. BCA's present dose of hydrochlorothiazide is appropriate and should not be increased to the maximal recommended dose of 50 mg daily, considered high-dose therapy, because it may increase risk of electrolyte and metabolic side effects. BCA's potassium dropped to 3.8 milliequivalents per liter with hydrochlorothiazide, and further dosage increases may produce hyperkalemia, that is below 3.5 milliequivalents per liter, requiring correction. Her hyperuricemia may also be worsened. The slightly increased antihypertensive response expected from increasing to 50 mg per day is therefore not justified. Discontinuing hydrochlorothiazide and starting a different agent is an option, but it is not prudent to abandon the hydrochlorothiazide. She tolerated the treatment and experienced a reasonable BP response, and the hydrochlorothiazide will augment the efficacy of nearly any other agent that may be added and may benefit her osteoporosis. Let's now briefly discuss 2-drug regimens. The role of 2-drug regimens in the treatment of hypertension is very clear. Most patients require multiple agents for BP control. Adding a second agent to BCA's regimen is needed to reduce BP to her goal. She is a primary prevention patient, so 3 potential add-on antihypertensive agents that are considered first-line include an ACE inhibitor, angiotensin II receptor blocker, or a calcium channel blocker. Ideally, a combination of 2 drugs with different mechanisms of action should be selected to produce a complementary effect to lower BP. Adding an ACE inhibitor, or an angiotensin II receptor blocker to BCA's hydrochlorothiazide will result in additive antihypertensive effects that are independent of reversing fluid retention. Diuretics reduce BP initially by decreasing fluid volume, but maintain their antihypertensive effects by lowering pulmonary vascular resistance. BP lowering, however, can stimulate renin release from the kidney and activate the renin-angiotensin-aldosterone system. This compensatory mechanism is an in vivo attempt to neutralize BP changes and regulate fluid loss. An ACE inhibitor or an angiotensin II receptor blocker blocks the renin-angiotensin-aldosterone system, explaining why combinations of these agents with diuretics are additive. Data from the accomplished trials support combination therapy for hypertension. In this randomized, double-blind trial, 11,506 patients with hypertension were randomly assigned to the combination of an ACE inhibitor with thiazide diuretic or an ACE inhibitor with calcium channel blocker. After a mean follow-up of 3 years, the risk of CV events was significantly lower with the ACE inhibitor with calcium channel blocker combination. Switching BCA's hydrochlorothiazide to an ACE inhibitor with calcium channel blocker may be more effective in lowering cardiovascular events than adding an ACE inhibitor to her current hydrochlorothiazide. This would be an acceptable modification. However, considering her response to hydrochlorothiazide, simply adding an ACE inhibitor is also reasonable. Let's now briefly discuss fixed-dose combination products. Several fixed-dose combination products including 2 or 3 drugs are available. Although individual dose titration is not simple with fixed-dose combination products, the use can reduce the number of tablets or capsules taken by patients. This has been demonstrated to improve adherence compared with using 2 separate single-drug products. Improved adherence may increase the likelihood of achieving goal BP values. Most fixed-dose combinations include a thiazide diuretic, and many are available generically. Other fixed-dose combination products combine a calcium channel blocker with either an ACE inhibitor or angiotensin II receptor blocker. These combinations, similar to a thiazide with an ACE inhibitor or angiotensin II receptor blocker, are highly effective in lowering BP. An economic advantage may even exist to using a fixed-dose combination if it allows the patient to receive 2 drugs for 1 medication copayment. The simplified treatment intervention to control hypertension study demonstrated that initiating therapy with a fixed-dose combination product according to a treatment algorithm was superior in attaining goal BP values when compared with usual management according to national guidelines. These data further support using a fixed-dose combination product for initial therapy. BCA is a candidate for fixed-dose combination product. If the combination of an ACE inhibitor with hydrochlorothiazide is selected for her, many options exist. All of the products with an ACE inhibitor also include hydrochlorothiazide at the dose she is currently on. If the combination of an ACE inhibitor with a calcium channel blocker is selected, fewer options exist, but there are products that contain an ACE inhibitor with a dihydropyridine calcium channel blocker or a non-dihydropyridine calcium channel blocker. Cost should be considered because this is a concern for BCA. Multiple ACE inhibitor with thiazide diuretic combinations are available generically, but there is only one generic ACE inhibitor with calcium channel blocker combination. Many angiotensin II receptor blockers are gradually becoming generic, so those may be potential option as well. Therefore, a combination of angiotensin II receptor blocker plus thiazide diuretic may be an option too eventually. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 278.